Good morning, everybody. Welcome to Grand Rounds. Usual reminders from me. If you're online, make sure you stay muted, but more importantly, if you have a question or comment for our speaker, you can type it into the chat box. I will be watching that chat box for you. And if you're in the room, you'll just get the microphone from me, so for the end for questions. But now I get to turn things over to the important people, and here's Dr. Whiteman to introduce our speaker and lectureship. Thanks.
Welcome. Thank you to those who came in person and for those of you online. To our 19th annual Treuman Katz lectureship. I'm Aaron Whiteman. I'm one of the co-directors of education for the Treuman Katz Center for Pediatric Bioethics and Palliative Care. Before introducing our speaker, I just wanted to take a few moments to acknowledge Treuman Katz, for whom this lectureship is named. Treuman was president and CEO at Children's for 26 years, from 1979 to 2005. And has been recognized for his visionary leadership, guiding Children's to financial stability, developing broad-based community support for the hospital and its mission, and for expanding subspecialty services at Children's and developing regional clinics to meet families and patients closer to their homes. During his tenure at Children's, some of Treuman's accomplishments also included the development of a strong an effective partnership between the University of Washington School of Medicine and Children's, one that serves as a model program for other academic private partnerships, along with helping in creation of the Seattle Cancer Care Alliance, and the development of research programs here at Seattle Children's as well. Another accomplishment of Treuman's was his commitment to developing the first Center for Pediatric Bioethics, which emerged out of his longstanding interest in quality of care and respecting the roles of families, as well as an emerging appreciation of the role of clinical research in advancing pediatric health care. In honor of Treuman and his incredible achievements and contributions, the Seattle Children's Board of Trustees established the Treuman Katz Center for Pediatric Bioethics, now the Treuman Katz Center for Pediatric Bioethics and Palliative Care, as well as this lectureship, the 19th, which occurs annually, the 19th of which we will hear imminently. So thank you to Treuman. And now let me introduce our speaker for today. It's really quite a pleasure to introduce Dr. Mark Navin. Dr. Navin is professor and chair of philosophy at Oakland University, a lecturer at Oakland University William Beaumont School of Medicine, and clinical ethicist at Corewell Health. His research is primarily in clinical ethics and public health ethics with a special interest in vaccination. His books include Values and Vaccine Refusal, Hard Questions in Ethics, Epistemology, and Healthcare, and with Katie Atwell, America's New Vaccine Wars, California and the Politics of Mandates. His articles have appeared in numerous leading journals, both medical and bioethics. And we're thrilled to have Dr. Navin with us this morning, as he'll speak to us about pediatricians as public health enforcers, ethics and politics in the era of vaccine refusal. Please join me in welcoming Dr. Navin.
Thank you for that warm welcome. Good. Thank you to my hosts, and both here at Seattle Children's and at the Treuman Katz Center. It is not just the world's or the country's first pediatric bioethics center, but it is, I think, clearly the best. And I'm indebted in particular to the Dougs, Doug Opal and Doug Diekema, as mentors, as visionaries in the field, and as people whose work I will be ripping off ruthlessly today without sufficient credit. So I will give some of the credit here right now. So here's the claim. I think pediatricians have been at the forefront of two major innovations in public health governance, in immunization, politics, since before 2016, but 2016 is a very important inflection point. And the two things I'm going to talk about are clinic dismissal, which is usually described, that's physicians kicking patients and families out of clinic if they don't agree either to vaccinate at all or vaccinate on the recommended schedules. I will talk about a variant of that called non-acceptance as well, but I'll use dismissal as the general descriptor. And then non-medical exemption eliminations. Right? So most states in the country, until very recently, well, it's still the case, I suppose, have non-medical exemptions to their school and daycare vaccine mandates, and the AAP has been pushing and been at the forefront, both in terms of advocacy, but also on the grounds in some state legislatures in pushing for these changes. I think these are often underlooked for their significance in how they've changed immunization governance in our social order. First, these are mandates. They are both threats. Get vaccinated or you don't get primary care. Get vaccinated or you don't get daycare or school. They are often described in other ways. I think it's worth staring in the face what they are. Now, from the way I've described them, you might get the hint that I don't think these are really great policies. Reasonable people disagree, but I think that disagreement ought to begin with an honest acknowledgement of the kind of policies they are and what they do. And so I'm going to talk today about what these policies do and why I think that what they do doesn't justify having them. I don't think they achieve their immediate goals of increasing immunization rates. The evidence is non-existent or mixed. They likely have very bad downstream consequences. The sort of backlash we are living with is at least, I think, partially, maybe only in a small part, but at least partially in response to overreach by pediatricians and their allies in these kinds of governance. They violate children's rights. We're not good in America about talking about children's rights, but rights are sort of interests that are worthy of special protection, and I don't think we do enough to protect children's rights to care, school, or other goods. I think there's a legitimacy crisis we're facing. The very people you're trying to govern don't recognize this as a sort of power that the government even, or that pediatricians even have a right to govern, and you're seeing pushback through the courts and through the legislatures about trying to rein that power in. And I think, and this is very speculative, but I'm curious what you think, I think it expresses an unrealistic but understandable, what I would call eliminationism, a desire that these people and this problem just go away, and that we ought to use whatever force or power or control is necessary to make this go away because we are all so tired of it. So I'm going to talk about how we got here, how I think we got here. I'm curious if you think we got here in different ways. This will be very brief. How these policies can be justified, or can they be justified? I'm curious if you think I'm uncharitable, if I'm missing some things. And then how I think we can do better. The problems are real. Kids need to get vaccinated. Unvaccinated kids do present some risks in our schools, in our clinics, in our communities. We need to respond to and manage this reality. I'm not trying to be naive. I also want to be clear, I'm not a pediatrician. I am friends with pediatricians. I am a colleague with pediatricians. I am sympathetic with the frustrations and the burdens, especially of providing pediatric primary care under these deeply imperfect situations. And so I'm curious, how can we better support the work we need to be doing? How did we get here? 2016 is a pivotal date, especially for AAP. It is the date when AAP said it was finally an acceptable option to dismiss patients who refuse to vaccinate. There's a lot more in that statement, but that's the big change. It's also the year where AAP, did I do something wrong?
I don't think it's true.
Okay. I'll keep talking and maybe someone can fix that. It was also the year when AAP first called on its members to work for the elimination of these NMEs, of these school-based vaccine mandates. I don't think I touched anything. Okay. So let me say something about these dismissal policies and where I think they come from. It's a long history. As long as there have been vaccines, there have been people who refuse vaccines. I also imagine, I don't have any data on it, as long as there have been vaccines and vaccine refusers, there have been pediatricians who have refused to treat these folks. We don't have good data on it going very far back. We only start to see discussion in the literature of these clinic policies in the sort of mid-2000s. One of the most celebrated ones comes from All-Star Pediatrics in Pennsylvania. If you've seen this policy, you'll know it. It has a very long discussion of Benjamin Franklin. And you can still find it. It has been modified somewhat on their website. It's striking. So AP News published it and shared it. Vaccinate.org still publishes and shares this as a sort of model policy. I'll come back to it later, but here's the sort of the meat of it. They say, we're going to work with you. We're going to accept you. We're going to work with you. We're open to alternative schedules. We're open to sort of delayed timelines. But if you just absolutely are a vaccine refuser, our relationship's going to have broken down and we're going to kick you out. I just highlighted these other bits because it's odd and it's still on their website. It says, we'll ask you to find another healthcare provider who shares your views. Now that's ambiguous between two things. One, shares your views that your child's entitled to primary care, which I think we all should believe, or shares your views that they're vaccine refusers, which there are some pediatricians like that, but very few. But then notably followed up with the idea that we would not recommend any pediatrician who would take you, so we're not going to make any referral. I'll talk about this question of recommendation and referral later, but I note here that in some ways this is less nasty towards the family than it is to their fellow pediatricians. which is my way of recognizing this is an issue that divides pediatrics as a profession. Okay, we do start to have some data in the 2010s. So O'Leary et al. Have a survey in 2015 that shows 26% sometimes, often, or always dismiss. So that's the core behavior. They have another survey in 2020 that shows that number is now up to 46. So in 5 years, the data goes from 26 to 46. Sometimes, often, or always dismiss. They also polled a different question, which is, do you even let these people in the practice in the first place? Or do you screen them with a phone call to not let them in the door? This is what we call non-acceptance. 42% have a policy to not let you in the door unless you agree to comply ahead of time. We don't have, as far as I know, maybe there's some in the field, any updated national surveys. I would be surprised if these numbers have gone down, especially after the COVID experience. I'm going to share some unpublished stuff. So we did a sort of fun study of all pediatric practices in Oakland County, Michigan, where I live, did a secret shopper. From the sort of family perspective, we had a male and female med student call each of the pediatric practices and say, hey, I've got a new kid, but I'm pretty sure we're not going to vaccinate. Will you take me? And to sort of get a sort of access to care perspective on this, because the data we have so far is all sort of national survey data, and we got unsurprising results. So half of them said we won't even accept you. Now, it could be that some of the ones who will accept you will also dismiss. So the overall number of ultimate inaccessibility of primary care is quite high, but that's half. Here's something else, just to sort of, I'm happy to talk more about this little study later. I have assumed for a long time, and some other colleagues have assumed, that these dismissal or non-acceptance policies were largely the function of private practice community primary care pediatricians. At least in our community, that's not the case. Private practice were more likely to accept vaccine refusers. It was the hospital system affiliated practices that were 2.5 times less likely to accept than to not accept. Disturbing. And then this referral bit, right, which I think is relevant to the All-Star Pediatrics policy. So of the 39 or 40, whatever it is, 39 who don't accept, only 12 consistently gave a referral. So 8 sort of referred for one of my sample parents, and the other one did not refer. But the upshot is just that of all the ones who were, very few, only a third referred, fewer than a third referred, and all those who referred, none of them referred to a practice that would actually take them. They all referred either to abstractly, oh, maybe you should go to Michigan Medicine, or they just named particular practices that themselves have non-acceptance practices. And then finally, AAP has moved on this, as you know, right? So Doug Diekema, right, authored the 2005 and 2013 statements, which are identical except for this tiny change. The change from you shouldn't dismiss to you should try not to. It's a change. 2016, the Committee on Bioethics is not an author, as I understand, and we get this acceptable option. And then Doug Opel is an author on the 2024 statement, which is in many ways so much better than the 2016 statement. It lays out the sort of ethics arguments about dismissal and non-acceptance, and it contextualizes this acceptable option bit, but it still has, as you see at the end of the quote, it is an acceptable option. So that's where we are today on AAP. So NME, the non-medical exemption elimination. The short story is Oxford University Press is still selling my book for $14.95. You can get it on Amazon today. Seriously, if you want, I'll send you a PDF. Just don't tell OUP that I did. Here's an even shorter story. Disneyland had a measles outbreak, and pediatrician and state legislator Dr. Richard Pan put together a coalition of folks who helped California become the first state in the modern era to eliminate non-medical exemptions. Unvaccinated kids could still only come if they had medical exemptions or had a sort of right to education under federal disability law. Similar successful efforts were launched in New York, Maine, and Connecticut. Other states launched efforts and for various reasons were not successful. Before they began this process, California was going to join West Virginia and Mississippi as the only states without non-medical exemptions. A bunch of states moved into the red, right, with California. West Virginia stayed there. Notably, Mississippi, through a judge's order, picked up a religious exemption in this process as well. We started to see a bit of the pushback. We started to see a bit of what you might call the backlash, which I'll talk more about later. If we're going to talk about AAP, In 2025, in fact, just some months ago, AP reiterated its commitment to the elimination of non-medical exemptions across the country. I said in seminar yesterday some things about this, but let me just say this right now. In doing so, AAP aligns itself with a clearly partisan-coded policy. At the same time, the policy statement says nothing about the political realities of vaccine refusal, right, or of the resistance in the pre- and post-COVID era to vaccine mandates. It is an odd statement. I think it's well-intentioned, but I don't think it's in touch with the world today. Doug Diekema and I have a draft about this, and Doug's suggested title for that paper was Read the Room. So that's where we are. Can these policies be justified? There are a lot of reasons given for these policies, a lot of thoughtful, good, committed people who advocate for these policies as the least worst thing we can do. And I'm sympathetic with them. I just don't think the arguments go through. The biggest claim is they're going to increase immunization rates. When it comes to dismissal policies, we just don't have any evidence at all. The AP statements are, at least the 2016 one, quite odd. They just say, oh, some pediatricians have had success in making these threats, and then parents agree. There's no other evidence in the literature that these coercive threats are successful. In the case of non-medical exemption elimination, the evidence is a bit different. I mean, some people will say, well, if you eliminate non-medical exemptions, non-medical exemption rates will go down. Yes, that is definitionally true. Good for you. But then they'll say, well, there are higher vaccination rates in the schools. Yes, that's true, though not as much of an increase as you might think. I'll say a bit about the California example in a second. But also, one thing you've done is shrunk the denominator. There are a bunch of kids who remained unvaccinated who are now just not in school. The homeschooling rate in California continued its rise and maybe accelerated, right, its increase in the aftermath of these more coercive crackdowns. And then folks will point to evidence in the literature, including some papers led by Saad Omer, that show that communities and states that have tighter or more difficult to get non-medical exemptions have lower non-medical exemption rates, and they will generalize to say, well, if you get rid of have higher vaccination rates, then they will generalize to the conclusion that getting rid of non-medical exemptions will further increase vaccination rates. I don't think that evidence base actually supports that conclusion at all. Happy to talk some more about that. So about the California case, which is supposed to be the big success story. Senate Bill 277, which is passed in 2015, goes into effect January 1st, 2016, but vaccination rates were on the rise beforehand. It's an interesting thing. Now you might say, well, the rise in the year beforehand was parents anticipating the law going into effect. But what about the increase in the year before that? And one story is a lot of different things were going on in California at exactly the same time, and it's very hard to attribute causation. But I would suggest that there's reason to think, this is a complicated piece of information from an excellent paper by Delmeter, there's reason to think that reforms to the conditional acceptance policy, which allowed kids who were delayed on their vaccine schedule, allowed kids who were to be temporarily enrolled in school, and then the schools were supposed to follow up and make sure within 30 days they got caught up. The schools did a much better job of starting to follow up on these kids who were on a sort of catch-up schedule. And that actually accounts, that's the drop of the tan, that accounts for almost all of the decline of kids who are not fully vaccinated. And indeed, if you want to talk about the blue stuff, which goes away, the non-medical exemption rate, that in the short-term period was actually almost fully made up for by increases in kids who were not up to date at all or under conditional admission, and that's actually a form of civil disobedience often by schools, mostly private schools. They just refuse to enforce this law. Like, this is what happens when you have a legitimacy crisis, but also the expansion of medical exemptions and disability accommodations. Furthermore, this chart actually misrepresents 277. 277 is passed in 2015, right, which is where the line is. It doesn't go into effect until the next year, right, which actually reflects what you saw on the other line, which is the gains all happen, right, or the declines in NMEs all happen before the law even goes into effect. So I think the evidence is at best mixed there. What about risk reduction? And here and on some of these slides, I'm just stealing from a nice conversation that Doug Diekema and Stan Block had a few years ago in the literature. Some people argue, look, you got to kick these kids out because you have to protect your other patients. And that's a good goal. You do have duties to your other patients. You ought not to expose them unnecessarily to risk. But first, we're not eliminating the risk. You're just pushing it off on others. You're pushing it off on colleagues who are going to take these kids or just their communities who are going to have them. Secondly, there are probably alternative means for reducing risks. Any clinic that allows sick kids in, who are much higher risk than a non-ill but unvaccinated kid, has ways to mitigate risks. And furthermore, it's just an odd idea that some risks, in particular disease transmission, ought to be driven as low as possible, even at the cost of denying people access to basic goods like school and education. If the appropriate, ethically justified risk reduction strategy was maximal in this way, all kinds of kids should not be allowed in clinic or school. Right? Kids who have ever shown a propensity to violence and might engage in violence again, at some time, but don't ever let them back in school. How could you impose that risk on the other kids in the school? I mean, what a horrific, right, and inequitable way to think about access to school that would be. But in some ways, that's the kind of way we're thinking here, and I worry about that kind of argument. And I worry about it because I think children have rights. We're terrible about talking about this in America. America is the only country that's neither ratified nor acceded to the UN Convention on the Rights of the Child. And furthermore, unlike many countries, especially European countries, who have acceded or ratified to that convention, we have not incorporated those human rights into our Constitution, into our legal frameworks. So we cannot even meaningfully say children have a sort of human right or a basic right to primary care or education. This matters in other contexts. Italy, for example, has daycare-based vaccine mandates that run through kindergarten, but they stop at first grade because in the Italian Constitution, children are granted a right to an education beginning with primary school, and vaccine mandates aiming at sort of risk reduction in school environments are understood not to trump that right. But we don't have this sort of vocabulary here. It's definitely not integrated in our legal systems, and I would suggest even pediatric ethics discussions get sort of trip over themselves sometimes when we talk about this. But I think rights to primary care and education are among the most fundamental rights we've got. Furthermore, these kids are innocent. They didn't do anything themselves to compromise these rights, and their parents made bad choices, but the bad choices their parents made actually made them more vulnerable, more worthy of protection and supervision. These are exactly the kids you want to be seeing, I hope, in clinic and keeping in school. Some people argue that if parents refuse vaccines, this is mostly the clinic argument, if parents refuse vaccines, well, that means the relationship's broken down and it's not going to be good for the kid or the family to keep them in practice. Maybe, and I think the AAP policy spells this out. It's possible that if over time the relationship breaks down because of the lack of productivity of these conversations and how emotionally charged or frustrating they get, that maybe it's appropriate to end the relationship. I don't deny that. But it doesn't follow from the fact that families refuse this one intervention that you recommend, that therefore they can't trust you on anything else. I know vaccines are special, but as you know, like all kinds of families smoke in the house, have unsecured handguns in the house. Lots of families, maybe most, don't have properly installed car seats. They do all kinds of things that are bad for kids and reject all kinds of your recommendations. And I'm not sure that means there's a fundamental breakdown in trust. Some people argue that dismissal from clinic is justified as a kind of conscientious objection. And the argument goes like, hey, vaccine refusal is so suboptimal and so bad for kids that it compromises my moral integrity as a clinician for me to participate in it. And so I have to protect my own sort of moral sense by not continuing to treat these folks. I think this is pushing in the right direction. I just don't think it's that great an argument. We often think of conscientious objection as being a refusal to participate either formally, right? This is a sort of thing from Catholic bioethics, but formally, where it's sort of my intention, right, to aim at the thing I reject, or materially, where I'm sort of actively supporting the thing I reject. But in neither case are you, while keeping this family in practice, either intentionally aiming at them being vaccine refusers. No, you're trying to correct that, and you're not materially doing it. You're not providing them resources to help them continue to be vaccine refusers. You are trying, in fact, to provide them materials, namely vaccines, to help them not be vaccine refusers. So I don't want to read into someone else's conscience, and I'm open to the idea that there are pediatricians that do feel a deep conscious objection to continuing to treat these patients. I would want to hear more about that. I don't think it's a direct line from the fact that it's suboptimal care. But even if you granted the point that conscientious objection could be a legitimate grounds for dismissing or not accepting these patients, well, now we're in a different framework, because conscientious objection, first off, is a response to a refusal to provide standard of care. So to invoke conscientious objection is to acknowledge that keeping these kids in practice is standard of care. But secondly, is usually understood to carry with it certain sort of duties. One, transparency, letting people know before they come to you, right, that you're going to use this this prerogative. But secondly, it's usually thought to have a duty of referral. If you conscientiously object to providing an intervention that is part of standard of care, but that is against your deepest moral convictions, It's usually thought that you have a duty to direct them to someone else so they can get this good or service that they have some claim to, namely, in this case, primary care. But none of the folks in Oakland County were referring, at least not effectively. And think about that All-Stars pediatrics statement. It doesn't just say, we don't refer. It sort of says it'd be wrong for us to refer. I'm not sure how to square that. Oh, a couple other thoughts, because I'm really just on dismissal at this point. I think there's a fairness issue, right? So there's an unfairness to vaccine refusal, I think, in terms of failure to make a contribution to herd immunity. It's a collective action problem. There's a similar unfairness to your fellow pediatricians, because for every pediatrician who refuses to take these patients, you increase the burden of everybody else who's left. So it's another way of saying, like, I actually think this is an issue that is dividing pediatricians, right? And I think it's worth paying attention to that sort of dynamic. And indeed, we saw this in our research because some of the practices that patients were referred to had previously accepted such patients, but that they had been receiving so many of these referrals that they had to stop taking them because they were overwhelmed. They were willing to take some, but not all. But they were getting them all dumped on them, and so they stopped. And so collective action problems have a variety of solutions, but they're mostly political. They need to be coordinated. They need to be solved collectively. And then here's something that Doug Opel and I have thought about, and I think it's worth emphasizing. I think non-acceptance, which in Oakland County at least is half of the pediatricians, and in the O'Leary et al. Survey from 2020 says it's 42% of pediatricians, that is not taking them in at all. I think that's worse than dismissal. Because at least with dismissal, you're engaging in some effort to take some share of the burden of dealing with these difficult families and providing primary care to these very vulnerable children. With non-acceptance, you are passing that off entirely. I'm open to arguments about physicians' rights to choose their patients that the AMA has fought for. I think of that largely, though, as a legal right and not as an immunity from moral criticism for how you exercise that right. And I think there are sort of good moral reasons to criticize the exercise of the right to choose your patients, to discriminate against vaccine-refusing families, especially if you do it absolutely. And notably, even though this non-acceptance stuff seems, between the national data and my county, between 40 and 50% of pediatricians seem to be doing it, it's not sanctioned by AAP. AAP says you can dismiss if the relationship breaks down after a long period of time to try to convince these folks. It doesn't say you can just have your secretaries screen people so you never have to see these folks at all. And finally, I think there's a primary care access problem. So overall in my county, 50% of pediatricians don't take these folks. Over 2/3 of the zip codes in my county don't have any pediatrician who will take these folks. And we're Southeast Michigan, which is car country. There is no public transit to speak of. Some of these folks are going to have problems reaching a primary care pediatrician. I've got a survey in the field. We're rerunning this project with family medicine physician practices. And we know from the national data they're much more likely to take these kids. Part of the story here is that we're going to solve this primary care access problem by pushing more and more of these difficult patients off on your family medicine colleagues. So I love the American Academy of Pediatrics, dedicated to the health of all children, but maybe dedicated to the health of all children except the really difficult vaccine-refusing ones. Those we'll give to our family medicine colleagues. And then this issue, which I hesitate to say much about at all because we're living it. I think we're in the middle of a backlash about a lot of things. And I think there are many, many causes, and people are going to spend decades trying to write about and figure out what those causes are. But I think at least part of it, and I've written, at least the book was about it, written some things more recently, at least part of it is about an overreach on behalf of public health, both during the COVID period, but also before the COVID period, in using coercive measures to promote vaccination that the population, at least big parts of it, just did not accept. And it created a constituency that could support what we're facing now. I want to be clear. I'm not blaming anybody, and from a moral point of view. It's not about blaming folks. But it is about saying when you do politics, when you do policy, you are sometimes responsible in a causal way for some of the predictable consequences of what you do. And coercive interventions that aren't understood to be legitimate by the population that you are governing have predictable consequences, and they have in the history of vaccine policy. And it's worth paying attention to those. And then here, this is perhaps the snarkiest and darkest thing I'm going to say, and I'm going to say some dark things. How then do you explain this? Because pediatricians I know are really smart and they're very thoughtful. If these the scientific evidence and the ethical argument don't support what they're doing, what is going on? And I suspect some of it is this. At least this is what some pediatrician colleagues and friends tell me. I just need these people to go away. They can't be in my clinic. I don't want them in my schools. In fact, my other patients are telling me they don't want vaccine refusers in my clinic. They're telling me they're not going to no longer be my patient if I continue to accept them. School districts are hearing this, right? I want you to be harder on the vaccine refusers. We don't want them here. And that's above and beyond the scientific evidence about risk or the ethical arguments about how to engage in risk management. I think it's a kind of changed social meaning. And we trace a bit of this in the book, but in the, up through the mid-2000s, even maybe the early 2010s, vaccine refusal was thought of as an idiosyncratic, eccentric, but ultimately, and not optimal, but ultimately tolerable parental behavior. Things change in the 2010s and certainly by the 2020s. We are divided deeply, and I think some of us are just done working with these people. But I don't think you can defend that ethically. Which is my way of saying you can understand this psychologically. I don't think you can defend it ethically. And I think it's shot through. This is from something I hold on to. This is from the White House COVID coordinator at the end of 2021. You people who get vaccinated, you're doing the right thing. If you didn't, you're looking at a winter of illness and death. That was the official White House communication. And I understand it. I felt it. We lived it. But this is not how you build legitimacy for public health policies. This is not how you try and justify governance, and especially coercive governance, to people who have different values than you. I understand it. I lived it. But that can't be the right way. What is the right way? I don't really know. The first thing is get ready. People talk about pendulums swinging. I don't think there's any reason to think pendulums are swinging back anytime soon. Whatever normal there was is not what we're going to go back to. Republicans may weaken or eliminate mandates the states they control. They may also attempt to allow like clinic dismissal and non-acceptance. There are laws in over 20 states introduced in legislatures that aim at one or both of these things. I hope none of them pass. Already it seems like Florida's laws are being watered, the sort of proposals are being watered down and may not pass as well. But the dam has been breached on this. Like, this is part of the reasonable conversation, at least on the Republican side of the House, about how we do public health policy. And they're both aimed to resist positions the AAP has staked out. I think public health institutions need to start preparing for more future outbreaks. They're coming. And we're not going to have the support from the feds that we maybe were expecting. And I think private institutions need to start too, right? We saw some of that during COVID. We need to be ready. What is it going to mean to manage disease outbreaks in your workforce? What kind of mandates are you going to be considering for your employees, for your schools? And then individuals and families need to think about it. Already, right, we want the make sure that grandma's got her pertussis booster before she holds the baby. I think we're going to be doing a lot more of that. And the shame is, of course, this pushes us towards even more social segregation, which you might think is at the root of some of the problems we're facing. Okay. I think we also need to give up on public health fantasies. I think there's a fantasy that there's the science, and if we follow the science, then we're going to get the good policy, and that clever, smart people will just find the right policy that's going to make things work. It's been called bright kid syndrome, and I think it's naive politically, it's naive historically, it's naive psychologically. I'm tempted by it because I have bright kid syndrome. I'm a philosopher who thinks somehow I'm going to make things better by writing and speaking. And if anything, I think this is a moment that shows that bioethics, whatever its value, is perhaps less relevant than we might have thought it was. History can humble us. I think it's worth paying attention to history and to the complexity and the sort of darkness of history. Our modern school vaccine mandates, they've only been around since the 60s and 70s. There have been vaccine mandates almost as long as there have been vaccines. There were smallpox vaccine mandates, but they were selectively enforced, both usually only during outbreaks, and they're selectively enforced both usually only against immigrants, poor communities, and communities of color. White people and white people with money in this country have never tolerated consistent application of truly coercive vaccination policies, which is why the school-based vaccine mandates of the 60s and 70s, they were not about controlling behavior. They were about responding to the fact the Nixon administration didn't re-up funding for vaccines, and so the measles vaccine that was newly developed, its uptake didn't go well, and they needed something that didn't cost any money to make it happen. But it wasn't about overcoming vaccine refusal, it was about triggering parental choice, right? In fact, the people who were involved in this say as much, right? We need a regular system, a system that works, a system that's cheap or free, that allows us to sort of socially norm and activate choice on vaccination. We needed some additional stimulus for people who are otherwise willing to do it. This is where our modern regime of school vaccine mandates come from. This is the argument they come from. And if you thought parental rights was a big issue in the 60s and 70s, you thought religious exemptions mattered then, they matter even more now. It is naive in the extreme to think that removing non-medical exemptions makes a small tweak to an existing policy. It radically changes them. It makes them coercive in a way they never were and were never intended to be. Right? They came with non-medical exemptions from the beginning in almost every state that introduced them. And it's no coincidence, for example, the same time they were rolling out, you were seeing religious exemptions to abuse and neglect laws. I hate those religious exemptions to abuse and neglect laws. I hate them, but they are pretty firmly established and have been, and as well, they're not going away anytime soon. And these are part of that same milieu. Okay, so a final thought. And then I hope there's some good time for discussion. So Ezra Klein, did anybody read this op-ed? Ezra Klein, right, wrote this very interesting op-ed where he says Charlie Kirk is practicing politics the right way. And I don't want to get into the details of it, but he's criticized by folks on the left in the extreme. And he's criticized in particular by Ta-Nehisi Coates. And then Klein has Coates on his podcast to discuss his criticism of Klein and of Kirk. And I don't want to get into first order questions about Charlie Kirk, not just because I don't want to be canceled, but it's also not directly relevant. But Andrea Pitzer, so now we're 3 degrees of separation removed from Kirk, so maybe I'm safe. Andrea Pitzer, who's a journalist and a fantastic writer and has some great books I recommend, she says, here's the problem with Klein, and she coins this term, which I love. Klein has bright kid syndrome. He feels he has to come up with the whole answer to the question that Trumpism represents. He's got to find the one compromise, the one tweak, the one nudge, the one thing that is going to solve this problem. And he's fallen apart because he's starting to realize he can't. And Coates says, Coates has a sort of darker view, and he has a historically grounded view. If you've read any of Coates' work, he's like, look, we human beings have been doing horrible things to each other in all countries forever. If you consider the long history of the problem at hand, it releases you from bright kid syndrome. There's very little you can do. You are at most going to be one piece in a solution in a chain of many people that begins when you were born and continues after you die. Vaccine refusal has been around forever. Vaccine mandate resistance has been around for as long as vaccine mandates have been around. I am not trying to reconcile ourselves to the world as it is. We should fight for a better world. But in some ways, it can be a relief to realize what you can do is quite small in response to the extremely powerful forces of history and politics and psychology that are on the field. What can we do? Let's take care of kids. I mean, I'll share with you. My kids are mostly grown. They're 18, 16, and 14. I went to nursing school. I'm going to graduate with a Bachelor of Science in Nursing in December because one response to despair for me, in addition to quitting Facebook, has been to try and find ways to care and be involved in my community. And I'm failing all the time. I'm getting choked up thinking about it, but I'm trying to find ways to do something. But let's try and keep kids in clinic and school. I mean, try and save yourself the burdens. You don't have to have the fight every time you revisit the conversation. We can manage the risk. Find evidence-backed ways to manage risk, including risk to your own well-being. Protect yourself. I criticize the AAP, but I love the AAP. Check out its toolkits on vaccine communication, right? I mean, Doug Opel has led the way on some of this, but there's so many evidence-backed interventions. They're not magic. They don't solve the problem overnight, but they give you something to do that sometimes works. And maybe it just works by giving you something to do that could work. Compromise, build alliances, take the wins where you can. Even if we're losing not as badly as we thought we might, if we're resisting in the right ways. And my last point is, and this comes from Josh Marshall, try and lose well. And what I mean by that is, in your efforts to resist the horrors that are coming on us, try not to compromise your core values, so that when you lose, you know that you fought for the things you really cared about, right, instead of giving in on them. And in particular, look, I love the American Academy of Pediatrics. Anyone at the seminar heard me yesterday, right? This is a professional organization that advocates not just for members of the profession, but for the health of all children. and has been engaged in a broad social and political project since its founding, and one that is amazingly admirable. And it would be shameful to abandon that mission just when we need it most. I wish I had more hopeful things to say. Maybe you will, and I look forward to hearing from you. Thank you.
Wow. Wow, wow, wow.
Mark, that was great. Thank you. And I wish we could have ended on a more positive note. But my question for you really stems from a critique out there regarding how we got here.
Yeah.
And I appreciate your sort of note that it's very complex. But one additional critique is we really did not engage with the public when we were making public health, or specifically vaccine policy, in a meaningful way. Yeah. Now, it's not to say there weren't efforts by the CDC and others to engage citizens at large in the value trade-offs of various policies as they were being considered. But those weren't sustained, and they were few and far between. And so it was that collective failure to put the public in public health that, as you said, is at least in part maybe why we're here today. So my question for you going forward is, how do we do better at that?
Yeah.
And how do we have really still retain in sort of our mission that really most of parents want to do two things. They want to vaccinate their child. That's still the majority of American parents today, and they want to trust their pediatrician.
Yeah.
So those two things, I think, need to remain front and center here as we re-engage the public on the way forward.
It's a great question, and I endorse the spirit of it, and I don't have good answers, but I'll say a couple things. And so one is, we have a tendency in this country, and have had a tendency, to think of vaccines and vaccine policy as a matter of natural science, when it's primarily a question of social science and humanities. It's primarily a question of, social institutions, people's socialization to certain kinds of behavior, responding to sort of historical trends and realities. And the fact that, you know this better than anyone, try to get a social science research project funded by NSF or NIH on vaccine uptake. I mean, Sodom and others, and you surely know that that's a very difficult thing in the past, and obviously no easier now. I think in particular, we need partnership with public health, because public health is struggling too, but I think they're often thinking about these things in better ways. So my county in Oakland County in Michigan, had a substantial measles outbreak in 2019, soon overshadowed by COVID. But within a week of that being notified, they'd given 2,000 doses of MMR to members of the Hasidic Jewish community where the outbreak was located. And they were able to do that because they had long-standing relationships with the Council of Rabbis, who met regularly with the health department. And indeed, they had the immunization and public health champions who were members of those communities, right, who were themselves directing programs in their communities with support from the health department. And I'm not saying pediatricians have to do that, but I think pediatricians do have some resources. As you say, they have the trust of their patients, their families. There's no trust for CDC or ACIP anymore, and maybe rightfully so, but people still trust their pediatricians. And I talked yesterday about how can pediatricians be political, and I'm not saying pediatricians ought to be an appendage of a particular political party, but these are political goals, and maybe that trust can be used. Maybe those relationships can be used to try and promote towards what we know is good. And I don't know. But I think it's in our communities, it's in our families, it's in our clinic relationships, and I think taking the sort of public health framework about building our social networks in our communities where we find them. That's where it's got to start, because the feds are not going to save us.
I have a comment and then a question. As much as I would also like to end on a more hopeful note, I have something more pessimistic to say. I read a comment online that something that's happening in places like Florida, in addition to elimination of vaccine mandates and a declining vaccination rate, coincident with that is also less access to developmental evaluations and developmental services and care for children. And so we might anticipate that along with declining vaccine rates, we will see declining rates of developmental challenges like autism because there's less diagnosis and less access to care, and that may further deepen this sense that vaccine refusal is the right thing to do. So I share your sense that things will get better before they get worse.
Or the other way around, maybe.
I mean, things will get worse before they get better. Yes, sorry. Darn it. I do have a question, though. There have been some places that have toyed with the idea or tried to pass regulations similar to other public health regulations that allow teenagers to consent for certain kinds of public health activities, like care for sexually transmitted illnesses. And there are some places where they've toyed with the idea of letting adolescents consent for vaccination. And I'm curious if you see that as helpful, not helpful, and why.
Good. Well, so maybe I'll make a distinction. From an ethical point of view, I think it's straightforwardly the right thing to do, right? So these young people can usually engage in ethically meaningful informed consent, right? And it's beneficial for them to be able to make these decisions. And it's a way to overcome parental refusal objection. From a political point of view, I am much less confident because there's very little that upsets and motivates the parents' rights folks than efforts by technocrats to sort of bypass parental rights and decision making. And so backlash looms large here. I mean, I might say something similar about questions about gender-affirming care and the lack of care that some advocates of those positions have exercised in talking about the limits of parental rights. From an ethical point of view, happy to be convinced, right, that you're doing the right thing, but backlash is a predictable political reality and has to be managed, and it's a terrible thing. So I don't know. I mean, is that, so on ethical level, yes, and on political level, boy, I don't know, but I worry.
I guess I'm looking for a little bit more advice for the general pediatrician. I concur with your conclusion that there's not a lot I can do. I'm a general pediatrician for 16 years in New Jersey. I worked in a practice that would dismiss patients if they didn't start vaccinating by 12 months of age. The argument being it gave us a year to talk with them and try to convince them that this was worth their child's health to try to vaccinate. And in that time, there were probably 3 to 5 patients who I actually made success with, and 16 years of not making any success with the others. I've since been part of practices in Virginia and here which accept non-vaccinating patients, and the argument being, I'm not going to kick them out. So in that New Jersey practice, there were, I said that wrong. There are about 3 to 5 families who developed such a rapport with us that they agreed to vaccinate because they didn't want to be kicked out, only because of that was our rule. But that was it, 3 to 5 in 16 years. And I think similarly here, there have been maybe a handful more who have listened to me with that trusted relationship over time and started to vaccinate their kids when they didn't really want to. But it's been handfuls in either case, whether we kick them out with a dismissal policy and families agreed to do it just because of that handful change, or whether we talked over time, developed that relationship, and they agreed to vaccinate when they didn't want to. Still only a handful of cases. So overall, I agree with your assessment that there hasn't been much success either way.
Yeah.
So I really would like to have a little bit more efficacy in making some benefits, making some progress. Can you give me any more hopeful advice on how to change the outcomes?
Well, let me start by just affirming what you said and maybe putting a different spin on it. I don't think that a good reason to either dismiss or not accept or keep is because you think that's going to change parents' minds. I'm open to the idea that dismissal is appropriate, right? So if you are overwhelmed by these folks, and maybe even non-acceptance in some cases is appropriate. I hear people in especially adult medicine talk about setting limits on the number of Medicaid patients they can take, given lower reimbursement rates, and that they financially can't run their practice if they go above a certain percentage of having these patients. I think it's probably not great to take none of these patients, but if you won't do at least some share, that's the problem. But I don't know that you have to take all of them that want to come if that's going to be too burdensome for your practice. And I think maybe something similar is true when it comes to dismissal or non-acceptance. But I think just saying, again, where I agree, the reason to keep them or to kick them out or not take them can't be because you think it's going to change minds, because I don't think it does. I mean, I think, and maybe this is saying no, I don't have any more reason for hope, but it's about reorienting. These kids need primary care. They really need it. And they really need other adults in their lives, even if you're only seeing them for 10 minutes once a year, who are putting eyes on them and care about them. And I think that's, if not hopeful, at least a central good. And if you can find a way to keep taking care of them, that's a goal worth pursuing. So, no, I'm sorry. But I tried to spin it.
Thank you so much for this great talk and really fabulous work. As a general pediatrician who works at UW and here at Seattle Children's, I'm really grateful that we don't dismiss anybody and that we accept, we have a full policy. I have many families, a handful of families in my practice that I've worked through negotiating around vaccine refusing, and I think that some of Doug's work has been really helpful for us in terms of understanding that so many people are hesitant, and if we provide a strong recommendation. I just came off of a week in the newborn nursery, and we have a definitely increase in the number of people who are initially not accepting the hepatitis B vaccine, and when we talk to them more about it, they are accepting it. So that does make me a little bit hopeful that we can overcome some of the resistance that we're seeing because of media. I'd say the thing that I feel most troubled by as a pediatrician is that, you didn't really talk as much about social media. I think we are, the 2010s and 2020s, we are dealing with the social media situation. And one, I think, challenge is that social media is not at all ethical. It is like so unethical in so many ways in terms of what is distributed and how misinformation and disinformation gets promulgated so quickly. And I'm just curious if you could comment on what we can do around that, which I think is one of the leading causes of what we're seeing in terms of the really big rise in these situations that has become more and more what we spend our time talking about, whether it's the newborn nursery or in clinic or here at the hospital inpatient.
Look, I think you're right. I mean, we were talking about political polarization, the inability to have meaningful conversations across difference and to compromise. I have 3 teenagers, maybe the inability to make eye contact, it seems sometimes. Surely I want to put a lot of blame on social media. I think there's a Nobel Prize to be won for someone who can figure out how to solve that problem, and so I'm not going to speculate about it. My deep hope is that we are learning something about it right now, and that the next generation is going to be a lot smarter about it than I was. My kids walked home from school, and we didn't have a phone at home, so they got cell phones at 12 or 13, and we weren't smart enough about locking down social media. And boy, they tell me that if they ever have kids, they'll be smarter about it than I was. That's the small amount of hope I can have, because I don't know. I think you're right that it's a huge problem.
Hi, thank you. Jeff Ogeman, our Chief Medical Officer. And so we set him off for the wrong line in Starbucks earlier, so I'm sorry about that. But,
I'm glad I was friendly at least.
Yeah, you were very
okay.
Good. Yeah. Just a reminder that, just as with you, all tertiary quaternary hospitals don't dismiss. So I think your comment that they need care is so critical. We're going to have these kids they'll have cancer, they'll have hydrocephalus, they'll have everything else that we have to take care of. But I do want to ask, is this really it's not natural science versus social science. This is a marketing problem. And I'm not seeing a lot of, I love the Travis Kelce commercials with the get 2 shots. Nice. Did that work? And at one point I thought, well, maybe we should go into Idaho with a Duck Dynasty star to promote vaccines. Now they all died, so that would have been a bad approach. But is there any, should we just get the best Madison Avenue firm out there and figure out how to?
Yeah, I think that's right. I don't think we disagree. I think that's a social science, that's a psychology problem, right? That's a marketing problem. How can we harness people's identities and their values? How can we pay attention to people like Haidt or Kahan or Doug Opel, right? About how we can use the various shortcuts we engage with all day long in making decisions towards a pro-vaccine bent, because those sort of biases and heuristics are being used all the time to direct the other way. Yeah, you're right. Vaccines have a terrible marketing problem, right? Not the least of which reason, as many people note, is it's not clear what problem they're supposed to solve for parents of a very healthy child who don't see any polio around. And as we know, trying to market them by scaring the heck out of people, more often than not, makes them scared about vaccines rather than about polio. So again, I think we need to be smarter about the social science, and part of that is marketing. But that's, we need psychologists, right, in some ways leading us, or psychology-informed pediatricians leading us, rather than folks just saying, here's the immunology, here's the epidemiology, let's follow the science, as if that solves any problem at all, rather than making them worse.
Hi, Dorothy Miller. A little different perspective. So I lead our government relations portfolio here at Seattle Children's, and I think actually building a little bit on Jeff's question, thinking about the political piece, right? Do you see off-ramps for de-escalating how politicized vaccines have become? I think you mentioned at the federal level, like give up, but I'm particularly worried. I think we serve the Whammy region, right? So we have Alaska, Montana, Idaho, and Washington State, very different politically. I think to your comment on Madison Avenue, there's no one who really knows how to talk to Republican leadership about vaccines effectively. And so do you have thoughts, ideas, glimmers of hope in this area?
Yeah, maybe I'll just share the dark bit. Like I had greater hope for Senator Kennedy from Louisiana. What did you say? Cassidy. Oh, was it Cassidy? Oh, I thought it was sorry. The Louisiana senator who was a physician. I am hopeful. I am hopeful for the possibility of regional and local attempts at solutions, right? So the alliance of the West Coast states that are going to bind together to make vaccine recommendations, and in some ways try and bypass ACIP, gives me some reason for hope, right? Michigan's doing a similar kind of thing. We just voted that when it comes to child vaccines, we're going to affirm the AAP's schedule, right? Bypassing ACIP. It's messy, and you know what? AAP should not be, in an ideal world, running national vaccine policy or doing so on a state-by-state basis. But I think there's some room for professional societies. You know what? The insurance companies have been smart so far, saying they're going to continue to cover these vaccines that were, like the AHIP statement, right? They're going to cover all the vaccines that were recommended by ACIP up until September of this year. They've been good so far. The hospital systems I've talked to in Michigan are being smart about this so far. Maybe there's a way. Of course, we need a functioning federal government, but maybe we can piece something together in the interim so things aren't going to be as bad as they might otherwise be. I think there are a lot of people working very hard and trying very hard, and we're going to make a lot of missteps, but I'm optimistic some of those attempts to glue our little paper clips and toothpicks together are going to work.
So we are at the hour, so please join me in thanking Dr. Navy.
Thank you.